PharmD at the Ohio State University College of Pharmacy, Megan Zimmerman, a PGY2 in solid organ transplant at Michigan Medicine, Vivian Pham, a PGY2 at Baylor St. Luke's Medical Center, and then Emily Parody, a PGY2 in pediatrics at St. Louis Children's Hospital. In a moment, I'll turn over to the speakers to begin the presentation, but first there are a quick few notes. If at any point during the presentation you have a question for the speaker, please submit it by using the chat functionality on the left-hand side of the screen. We will take questions at the completion of each presentation. The slides from today's presentation will also be posted on the ACCP website in the section titled Webinar Slides after the presentation. And lastly, if you experience any technical difficulties during this webinar that are not fixed by logging out and refreshing your internet connection, please make the presenters aware that the chat functionality. There is also a live chat in the upper right-hand corner of your screen where you can get live technical support from any meeting. Now, without further ado, I'll turn it over to Sheridan McKenna for our first presentation.
Hello, guys. Thank you so much, Dr. Exon. My name is Sheridan Tassi, and I am a fourth-year student at The Ohio State University. And I have my partner with me today. We worked on this project. We both did a summer internship at Mayo Clinic, and we had the wonderful opportunity to work on this. So I'll let her go ahead and introduce herself as well.
Thank you, guys. My name is McKenna Kleibrink, and I'm a fourth-year student at Texas A&M School of Pharmacy. And so today we're going to be talking a little bit more about our project. We were able to work with Dr. Adley Limke with Mayo, and our project was over streamlining prior authorizations when looking at antifungal prophylaxis for our thoracic transplant patients. So our learning objectives for today are to understand the challenges with prior authorization approval for both itraconazole and posaconazole when looking at the heart and lung transplant recipients, reviewing our quality improvement initiative, which we'll go over later a little bit about what we aim to do with it, and then how this would impact PA approval rates, hopefully improving them. And then to discuss strategies to streamline antifungal PA submissions across the health system in order to make this process a little smoother and reduce time that it takes to approval.
And then to give a little background on exactly what we were doing and why we're doing it. So thoracic transplant recipients, TTRs, are at an elevated risk for invasive Aspergillus infection. This is primarily due to the immunosuppressive therapy that they're on. And so it is guideline recommended for itraconazole, posaconazole, and other various azoles for prophylaxis for these heart and lung transplants, but neither of these drugs have FDA approval or indication. So often a PA is required just because it's there for that extra boundary, which we usually see with non-FDA approved drugs. So a lot of times PAs, as many of you guys probably know, are very time consuming, and it can lead to many denials as well.
So, as Sheridan said, the objective of our study was to evaluate whether streamlining the PA process for our system increased the initial approval rates for itraconazole and posaconazole in our TTR patients, and to assess whether the intervention actually reduced the time required to kind of the transitions of care between inpatient and outpatient. Our hypothesis was that streamlining this process will increase the proportion of prescriptions approved on the first submission. And then by implementing this guide for our pharmacy staff, it'll reduce delays in medication access for our patients.
So for our methods, we use the define, measure, analyze, improve, and control framework. So just to kind of run through it a little more in depth, we defined it as itraconazole and posaconazole being guideline recommendations for Aspergillus prophylaxis, but as we stated before, PAs are frequently denied by the pharmacy benefit managers measured. So we were looking at itraconazole and posaconazole prescriptions, PAs for TTRs from August 2023 through September 2023. We analyzed common denial reasons, the most common ones being inappropriate diagnosis codes, so ICD-10 codes, they usually not being FDA/not FDA approved indications, and usually they wanted clinical documentation in addition to support why we were requesting this. We were hoping to improve, alongside our health systems outpatient PA team, a practice guideline to help streamline and give a kind of system for completing these PAs, as well as updating current pharmacist PA submission templates. And for our control group, we measured the outcomes from November 2023 through December 2023.
So more specifically, the interventions we had, we did compare the data from before and after this change, and we gave a month in the middle to allow for an adjustment period. So kind of the changes that were made, the best practice guide was essentially to maximize the chance of approval. So this included a letter to the PBM and the people working on the PAs, as well as attaching the guidelines and literature that supported the use of these drugs in our patients. Additionally, we went through all of the denials and then the approvals. When looking at the approvals for our PAs, the ones that were identified like common themes between the ones that were approved, we encouraged our staff to use those particularly. And then for pharmacist documentation, we updated the documentation that were submitted by transplant pharmacists and even made this integrated into Epic. So that way everyone was kind of on the same page and hopefully making this process smoother.
And then for results, so just kind of give a baseline, majority of our patients were lung transplant patients, although we were looking at both. There was an increase in PA approvals following our intervention, which was very exciting. As you can see in our chart, we went from about 84% to 92%. Our average time to PA approval decreased by 1.5 days, which is awesome because when you think about that, that's like hospital stay and quicker people get to go home. Some other things to point out is that we had less denials as well, and then initial denials approved with appeals also did go down, but it's because we had less denials.
Going over our outcomes for our project, we kind of surveyed the stakeholders that were involved, most of the pharmacists, and they endorsed that there was a reduction in time to approval as well as our results. This also led to them feeling more like involved in the process and feeling like it was easier on them overall. As Sheridan said, there was a lower time that it took to get approval. So the earlier discharge led to lower costs for the hospital systems as well as the patients. And then this process was streamlined. The use of inappropriate ICD-10 codes was completely eliminated. So really by evaluating those denials prior to our intervention, we were able to get rid of those completely. So this was something we all found very significant from our project. And in addition to the lower hospital time, this was kind of one of the major things that we were excited about.
And then as far as key takeaways, so implementing this initiative was very successful in streamlining the process of PA approvals. Unfortunately, our results were not statistically significant, but as McKenna said, we did have big improvements, and you kind of have to weigh the values if maybe it's not statistically significant, but there is some clinical significance if thinking about the patients get to go home sooner, as well as were able to educate the prior authorization team and get rid of ICD-10 codes that were inappropriate. We also received a denial citing not medically acceptable even after implementation, still, even though we were showing appropriate evidence. So that was something we still saw even afterwards, but this just continues to highlight the need for addition of this indication in medical references used by pharmacy benefit managers. That way they're able to see that this is an appropriate medication and is needed by patients. And then here are our references.
Great job, McKenna and Sheridan. Does anybody have any questions for them?
I think I see one in the chat that said, could you share more information on the inappropriate ICD-10 codes that you found were used. Yeah, it usually was, there was like a wide variety. Some of them were even as like, just like, one of them that we saw a lot, the most common was just doing the Aspergillus ICD-10 code. There wasn't like for transplant. That was one that we saw a lot, but then there was even some that didn't even relate to Aspergillus or transplant at all. I think that component of also really educating the prior authorization team also helped. But the most common one was probably just saying it was for Aspergillus, usually got denied.
Yeah, I think a lot of them were like treatment of Aspergillus, and so not the specification that it was prophylaxis and not treatment, and that kind of led to the denial of that without showing that there was active infection, that they couldn't approve it.
All right, great job. And if there's no other questions, we'll turn it over to Meg.
Great. Hi, everybody. So thank you, Haley, for the great introduction. The project that I'm presenting on today is about the association of early graft dysfunction and CYP3A5 genotype with tacrolimus exposure in adult kidney transplants. So we can go ahead and go forward. I have no conflicts of interest to disclose today. Just wanted to be straightforward with you. These are the abbreviations that we'll use throughout the PowerPoint. We can go ahead and skip this slide, though, because I will define as we go. This is more for completeness when you go back and look at the slides. So the focus of my project, of course, is tacrolimus or tacrolimus, the calcineurin inhibitor we use as part of our maintenance immunosuppression. Historically at Michigan Medicine, we actually used kind of a standardized dosing protocol. So we gave immediate release tacrolimus at 0.05 or 0.075 mg per kg every 12 hours following transplant. And then, of course, after that, probably like most of you, we use therapeutic drug monitoring to start monitoring levels around after 2 or 3 doses. Next slide, please. But tacro, of course, is a little bit tricky to monitor and to dose. So we have some pharmacokinetic considerations. Both hepatic and intestinal metabolism occur, and they occur via CYP3A4 and CYP3A5 metabolism. So where this gets a little tricky, of course, is when we look at the pharmacogenetics aspect. So for the purpose of this study, we looked at the CYP3A5 genotype specifically, and then we looked at those that had CYP3A5 star 1 alleles, which we called expressors. So those are functioning alleles, versus those that didn't have that star 1 allele, so our non-expressors. And as expected, we would expect our non-expressors to have a higher dose normalized concentration or just a higher trough than we would those who were expressors. Thank you. Go ahead and slide. And then things get a little bit interesting, though, when we consider not just CYP3A5 expression, but also graft dysfunction, or in the case of this study, just kidney dysfunction. So in this study by Kerwin, they use midazolam as a marker of to measure midazolam concentration in patients that came into the ER with differing levels of kidney injury. So using that rifle criteria that you can see there. And then on top of that, they had looked at the differential effect then of those with CYP3A expression, non-expression, and you can see the different star alleles there that they studied in particular. So the star one is going to be an expressor similar to our study. And you can see as the graph goes from left to right that the tacrolimus exposure or concentration increases not only as the kidney function decreases or worsens, but we also see that the non-expressors have higher concentration than the expressors. Next slide, please. So of course, being kidney transplant people, we wonder then what happens post-kidney transplant in those that maybe don't have perfect graft function. So this leads us to our next study that was actually done by Coopers. And so this was done in kidney transplant recipients, looking at the difference in tacrolimus exposure, but also dosing over the first 7 days post-kidney transplant. And so I know that hopefully you have bigger versions of this graph on your screen, but to orient you, on the left, we have CYP3A5 non-expressors. So those are those without the star 1 allele. CYP expressors on the right. And then along the x-axis, of course, we have the 7 days. And then on the left side, we have the tacrolimus concentration. On the right side, the tacrolimus dosage. And you can see really on the left side of the non-expressors that we started out using they started out using standardized dosing protocols for tacrolimus, but we saw a bigger concentration or higher initial peak in those patients that were CYP non-expressors. And at the same time, you can look at the dosing requirements, and those were also lower, giving over time as those doses normalized, as they did the therapeutic drug monitoring and adjustment. So on the right then are the expressors, and you can see just comparatively between the two graphs that there was a large difference in expression on post-op day 1 when they started measuring versus those that were expressors. So this led us then to our study, where we wanted to compare that effect of early graft dysfunction on tacrolimus concentrations in CYP3A5 expressors and non-expressors. So to do that, we had a couple of specific aims, just to break it down a little bit. We wanted to determine the association between early graft dysfunction and tacrolimus exposure just by itself. And then we wanted to look at the differential effect of CYP3A5 expression on top of that to see how that affected tacrolimus exposure. And then for our study design, this was a single center retrospective cohort study done at Michigan Medicine. We collected our data through our EHR, and then we have a genomics repository that we were able to collect our CYP information from. Our primary outcome we looked at was initial tacrolimus dose normalized trough concentrations on post-op day 2. That's very wordy, but this is what it looks like. I included the equation for completeness. So we looked at blood concentration, but also on the bottom then the first tacrolimus dose that was given based on milligrams per kilogram per total day. So this allowed us to look at concentrations of tacrolimus doses no matter what dose they got. This is why we chose to look at this as our primary outcome of tacrolimus exposure. Graft function following kidney transplant, we define this just a little bit differently than the previous study, where they looked at delayed graft function versus everybody else who had some sort of graft function that didn't require hemodialysis in the first 7 days. For our study, we looked at immediate graft function versus early graft dysfunction. So where that comes in is we defined immediate graft function as those patients in the first 24 hours saw at least a serum creatinine decline of 10% and at least a urine output average of 0.5 milligrams per kilogram per hour. Anyone else, regardless if they required hemodialysis or not, was placed in the group of early graft dysfunction or non-IGF. Inclusion criteria and exclusion criteria are really included here for your reference. There were just a few that I wanted to highlight. If you could move forward, please. Thank you. Where I'll go through most of these inclusion and exclusion criteria as we look down at who was included in our final research project or final patient population. But tacrolimus was drawn after at least 2 doses on post-op day 2 without a dose change. So I think that's really important to include. We're looking at that dose normalized concentration and also clinically relevant to when most of us would start dosing tacrolimus or changing doses. The CYP3A5 genotype also had to be available to us. And for exclusion criteria, our main one that I just want to highlight is any sort of medication that would cause a strong drug-drug interaction with tacrolimus was an exclusion criteria. So we went through and carefully scanned the EHR for those medications. Data collection, again, listed here for completeness. I'll go through these more as we talk about our results. Primary outcomes and the statistical tests used also included for completion, but I'm happy to answer questions at the end about it. And then our results. So of 383 initially screened patients, we started excluding based on if they had a previous transplant, tacrolimus, our Envarsus was used instead of immediate release tacrolimus, missing any genotypes like I mentioned before, or if they were enrolled in a research study at the time of transplant, some of those patients just received different immunosuppression and different inductions. So we were excluding those. Our next round of exclusions just came from patients who were lacking demographic data where we couldn't verify some of the variables that we collected. And then we had to exclude one, unfortunately, who didn't receive the same consistent dose of tacrolimus before we checked levels. So we were hoping for a consistent dosing model. So that left us with 314 patients total in our study. Baseline characteristics and results are included here, again for completeness, but I do want to highlight that between the 2 groups of immediate graft function and non-immediate graft function, both age and race were deemed significant. Our ethnicity and our kidney transplant indications were not significant in the study. However, our induction immunosuppression was significant. Depending on your institutional protocols, this might be kind of expected between those that have immediate graft function versus those at risk for dysfunction. But we also saw some difference in immunosuppression that was more statistically significant, and the number of tacrolimus doses received was also there was a difference that was significant, where actually those that had immediate graft function received more tacrolimus doses than those with non-IGF when we were looking at post-op day 2 levels. Other things to note here, weight was deemed significant, where those in the non-IGF group were weighed just a little bit more, a few more kilograms, and then the donor types were also significant, which again is probably to be expected that we would see more living donors on the IGF side. And looking at our first primary outcome, so we have tacrolimus exposure in immediate graft function versus non-IGF. So this is looking without CYP differences, just looking at the differences between groups. So I think if you go forward just a minute, there's a table that will pop up. Thank you. So you can see that between these two groups, there was actually some significance. It's cutting off the bottom, so I apologize. I'm just gonna pull it up real quick. There we go. So we had a higher tacrolimus normalized dose concentration in non-IGF patients versus those with IGF. That was deemed statistically significant with our p-value of less than 0.001. So you can see on the graph there that it's like a pretty wide range, but still significant between the two groups. And then if we kind of look at the differential effect then of not only graft dysfunction or early graft dysfunction, but we also look at CYP3A5 expression, you can see as we go from left to right visually that when we have expressors versus non-expressors, it goes up in concentration. But as we go from IGF to non-IGF, we also goes up in concentration. So if you go ahead and advance to, keep going just a little bit. Thank you. This is what we ran. We looked at the statistics as far as what was significantly difference between the two. So between our CYP3A5 expressors with non-IGF and IGF, no statistical significance. So we know that the non-IGF population had a higher tacrolimus concentration, but it wasn't significant. Between our CYP3A5 non-expressors, however, there was a significant difference between IGF and non-IGF. So our conclusions then are that patients with non-IGF had a significantly higher tacrolimus exposure compared to those with IGF. And amongst those that were CYP3A5 expressors, the association between graft function and tacrolimus exposure was significant. So actually approximately 30 to 40% higher exposure is what we were looking at between the new groups, or two groups. However, when you look at CYP3A5 expressors across the board, the difference between our IGF and non-IGF just was not significant. So the impact of this then, if we're thinking about our current practice of tacrolimus, here at Michigan Medicine in 2023, we actually started implementing pharmacogenomics-based dosing. So we have patients get CYP3A5 genotyped as part of their transplant workup. So for non-expressors, expressors that are intermediate metabolizers, meaning they only have one star 1 allele, and then our normal expressors are 2 star 1 alleles, you can see the differential dosing effects. Our recommendation, however, is to really consider for those patients who are at risk of early graft dysfunction or non-IGF, that we go ahead and reduce the dose by at least 30%. So on top of already reducing the dose for those that aren't expressors, adding an additional layer for those at risk of graft dysfunction. Limitations of this study come from really it being a retrospective chart review, not being able to control how many doses of tacrolimus patients might receive before a dose change occurred. So this obviously wasn't at steady state, but still very clinically relevant given where most centers start adjusting tacrolimus dosing. And then, of course, CYP3A4 is also a key player in tacrolimus exposure, but we aren't able to account for that just based on the data that we have. However, in the majority of the data that's out there, there are a lot of different CYP3A4 genotypes. Rarely are they clinically significant, and when they are, it's a very, very small difference in concentration or metabolism between the two. So lastly, I'd like to thank Jamie Park, or Dr. Jamie Park, and Dr. Amy Pasternak, who both were my mentors on this project and members of ACCP. And then I believe that's it. What questions can I answer for you?
All right, I'm not hearing any questions.
Okay.
Megan, great presentation. I will pass it on to Vivian now.
Hi, good afternoon, everyone. My name is Vivian Pham, and I'm one of the PGY2 solid organ transplant residents at Baylor St. Luke's in Houston. And my project was looking at the effects of fluconazole on immunosuppressions in our liver transplant recipients. So our learning objectives is to understand the pharmacokinetics of the interaction between fluconazole and tacrolimus in our liver transplant recipients, and then identify the appropriate tacrolimus dose adjustments during and after fluconazole administration, and then assess the impact of fluconazole on tacrolimus levels and clinical outcomes such as rejection and mortality. So a little background about um, liver transplant. So all of our patients would get immunosuppression such as tacrolimus, and this increases the risk for infections in our patients. So looking mostly at our invasive fungal infections, about 40% of our liver transplants do get invasive fungal infection, and the most prominent pathogen is Candida species. So looking at patients who are high risk for fungal infection, those criteria are listed on the slides. So for instance, prolonged hospitalization if they were on antibiotics before, multi-system organ failure, and then if they had fungal pre-colonization. So individuals who are on prophylaxis for fungal infections are either on nystatin, which are individuals who are at low risk, and then patients who are on fluconazole are high risk, and their duration is usually 3 months. So I mentioned that tacrolimus is our main immunosuppression, and it's a CYP3A4 substrate. However, if individuals are started on fluconazole due to the fact that they're high risk, it is a CYP3A4 inhibitor, leading to an impairment of the metabolism of tacrolimus, leading to the levels to increase. So these toxicities can be seen in our patients, such as nephrotoxicity and neurotoxicity. So most times we would usually start on a short course of fluconazole and switch patients over to nystatin to complete the 3-month prophylaxis. So in literature, there's really no data out there for what is the tacrolimus dose adjustment that needs to be done for patients who are started on fluconazole. So that's why I did this study to identify the appropriate dose adjustment required for patients who are on tacrolimus for antifungal prophylaxis. So our primary endpoint was looking at the percent change in our tacrolimus dose and levels after fluconazole discontinuation. So 2 weeks post discontinuation, and then secondary outcomes was looking at the dosing of fluconazole, rates of invasive and fungal infection at 1 year, and then biopsy proven rejection at 1 year as well, and then mortality attributed to fungal infections. So our study design was looking at single center retrospective chart review for patients who were transplanted at our site from January 1st of 2020 to January 1st of 2024. We included patients who obviously got liver transplant and they were on tacrolimus and fluconazole. So our prophylaxis dose at our site is 200 milligrams per day. And then we excluded patients who were not adults if their tacrolimus was not less than 6. And then if they had a percent change in their level or dose greater than 100%. So for screening, 205 liver transplant patients were screened, and 103 patients were excluded, so they did not meet those criteria. So 103 patients were included, and they were split between 64 patients in the less than 14 days group, and then 39 patients in the greater than 14 days group. We split that due to the fact that that's usually our duration of fluconazole at our site. For statistical analysis, so we just did descriptive statistics to analyze our data. Categorical data variables were summarized by percentages, and then continuous variables were summarized by mean and medians. So looking at our baseline characteristics, median age for our patients was about 56 and about 51% was males. Average weight was about 80, and then majority of our patient population was Caucasian. And then looking at renal dosing for fluconazole, so most of our patients had a creatinine clearance of 53. So looking at high-risk factors, majority of our patients were on broad-spectrum antibiotics prior, and they were hospitalized within 90 days. Their MELD score was about 29, and about 36%, 35% of individuals were on dialysis. So looking at our daily dose for tacrolimus, for our total, there was a 28% increase. So during the administration of fluconazole, the average was about 5.3, and then we increased our dose to about 8 for all of our patients. It was the same across for the less than 14-day group as well, but however, the greater than 14-day group had a less drastic change due to the fact that they could have been in the clinic and they were on tacrolimus and fluconazole longer, so you can see those effects less often. And then looking at the dose percentage, so this was a percentile after change for all patients, and then I did a box and whisker to assess the median for the two groups, and we can see the less than 14-day group had a greater percentage of increase of their dose compared to the less than 14-day group. And then looking at the levels between the groups, for total, we can see that the level was averaging about 9.1 with the use of fluconazole, and it decreased to 7.4, which was about 27.9% decrease. And then same thing for our less than 14-day group. And when you're comparing it to the greater than 14-day group, we can see that it was still about 27%. Now, looking at the percentages, we can see that when you're comparing the less than 14-day group with the greater than 14-day group, the percentage for our median was comparable between the two groups. So even with the dose adjustments, we still saw that the levels was not in the therapeutic range that we wanted. So looking at secondary outcomes, so usually fluconazole duration was about 11 days for our groups, and the median dose for our patients was about 2.6 mg per kg, which is lower than our standard dose of 3 to 6 mg per kg, since we do 200 milligrams per day at our site. Invasive fungal infection was about 21%, and we saw about 27% with biopsy-proven acute rejection within 1 year, and 2 deaths were attributed to fungal infection, which both of them passed away due to Candida species. So looking at fluconazole discontinuation, we saw that tacrolimus dose increased by about 10 to 30%. However, we still saw that the level dropped by 27%, potentially meaning that our target trough is falling below where we would like. So greater dose adjustments was made in the less than 14 days group compared to greater than 14 days group. And this as we can see that there was like high rates of rejection in our patients. So this shows that maybe the levels falling below that our goal resulted in us needing to be more aggressive with our tacrolimus dosing. So some limitations is that it's a single center retrospective study with limited sample size, and that when I was looking at the tacrolimus level, it was averaged over 3 most recent levels. However, if they were inpatient, we were able to get them daily dose close to each other. However, if they were in clinic, it's harder to get them in clinic to get the levels. So you'll see that they'll be like a couple of days apart. And then follow-up for our patients in the clinic setting was up to 1 week. So we should have followed up with patients in the clinic for up to 2 weeks. So our conclusion is that tacrolimus dose needs to be increased after fluconazole discontinuation to ensure that patients are still in therapeutic goal. That level is, we need to at least increase it by about 30%. And we see that rejection is a concern if we don't aggressively increase our dose. So further study needs to be done to assess the effects of tacrolimus dose adjustment 2 weeks post discontinuation of fluconazole and the use of fluconazole on rejection rates. And that's the end of my presentation. I'm opening the floor for any questions.
All right, I'm not hearing any questions, Vivian. Great presentation. I will turn it over to Emily now as our final presenter today.
Okay, thank you. Hi, everyone. My name is Emily Parody. I am one of the current PGY2 pediatric pharmacy residents at St. Louis Children's Hospital. Today, I'll be presenting my research my time as a PGY1, which was over single-dose cyclophosphamide for antibody-mediated rejection in heart transplant recipients. And at this time, I have no conflicts of interest to disclose. Our objectives today will be describing the importance of antibody-mediated rejection, or AMR, in heart transplant recipients, as well as describing the safety and efficacy of single-dose cyclophosphamide, or CP, for the treatment of AMR in heart transplant recipients at our pediatric institution. This timeline here is depicting the diverse diagnostic criteria that's been used for AMR over the years. And due to this diverse diagnostic criteria and variations in screening frequency, AMR has largely been underreported. However, we see that at the same time, through the United States 2022 annual data report, it showed that pediatric heart transplants had increased by 31.7%. There we go. However, in January of this year, the Pediatric Heart Transplant Society published a multi-institutional analysis that found 37% of patients who underwent heart transplant had features of AMR. So what this timeline is showing us is that despite the rise in pediatric heart transplants and advances in management, the rate of AMR post-heart transplant continues to be a concern in our pediatric patients. Risk factors for AMR include prior blood transfusions, history of a retransplantation, or a positive cross-match. Guiding principles for AMR management is largely composed of a multimodality approach consisting of suppression of our B-cell response through agents such as rituximab, as well as our T-cell response through agents such as corticosteroids. Elimination of circulating antibodies is achieved through plasmapheresis. And finally, inhibition of residual antibodies and complement activation is achieved through immunoglobulin, or IVIG. However, where does cyclophosphamide fit in this mix? Over the years, it has sparked interest for its unique mechanism of action, which works to inhibit B-cell proliferation. Cyclophosphamide is currently FDA approved for various malignancies and autoimmune disorders. However, it has been shown to be a potential treatment option in both renal and lung transplant recipients as a single intravenous or IV infusion for rescue therapy for AMR, or patients who have just failed conventional treatments. Now, data is modest in cardiac recipients. However, in 2002, when compared with mycophenolate monotherapy, the risk of rejection was 3.7-fold higher in sensitized cardiac transplant recipients treated with mycophenolate alone than patients treated with both cyclophosphamide and mycophenolate. And this study has largely served as the basis of use here at SLCH, but cyclophosphamide administration continues to not be largely recognized in our pediatric AMR guidelines. CP use is limited by significant complications such as bone marrow toxicity and hemorrhagic cystitis. However, Mesna, a chemoprotectant agent, is used in conjunction with cyclophosphamide to break down the urotoxic metabolite that can lead to hemorrhagic cystitis. In order to be considered for single-dose cyclophosphamide at our institution, patients had to have met 2 of the following AMR criteria, with the first being either a positive biopsy stain or elevated donor-specific antibodies seen on a 1:25 dilution, or through an element of cardiac dysfunction, which was defined as decreased cardiac index, decreased ejection fraction or fractional shortening seen on echo, or an increased filling pressure. We follow a protocol here for administration at St. Louis Children's Hospital. I have included dosing for your reference here. And you'll notice that we pre-treat all of our patients with Mesna and aim to maintain hyperhydration for 24 hours around cyclophosphamide administration. We're also grabbing various lab values to monitor for toxicities. And then patients are also able to receive scheduled Zofran to minimize the emetic risk. Now, during my research, this was the current cyclophosphamide protocol. However, we have made a few changes after my research to include specifically regarding our post-hydration fluids. So rather than running for 24 hours, they will now run for 12 hours after receiving cyclophosphamide. We conducted a retrospective review of heart transplant recipients between 2018 and 2024. We included any heart transplant recipient who received cyclophosphamide for AMR, and our primary objective was to determine the efficacy of cyclophosphamide through examining graft function, DSA response, and cellular response. Overall, 37 encounters were identified during this time frame. 25 were excluded, largely based on the receiving cyclophosphamide for diagnosis unrelated to AMR. And overall, we included 12 encounters or 11 patients in our primary analysis. Key baseline demographics that I want to point out is that our median age was 16 years with a wide range of 3 to 32 years old. 55% of patients had a positive cross-match at time of transplant. And then all of our patients received both thymoglobulin and methylprednisolone as part of induction therapy. When we look at key encounter characteristics, we see that the median interval from transplant to rejection was around 2 years. And patients largely met AMR criteria based on some element of cardiac dysfunction, and then a combination of either elevated DSAs or a positive biopsy that was indicative of AMR. Key baseline therapy characteristics showed that the number of rejection treatments prior to cyclophosphamide on average was 1, and you can see we had a wide range of treatment modalities for previous episodes of rejection. Maintenance immunosuppression prior to cyclophosphamide showed that 92% of patients had been receiving mycophenolate, 83% had been receiving tacrolimus, and 42% had been receiving corticosteroids as part of maintenance immunosuppression. Key outcome criteria that I want to talk about today is that 42% of our patients did experience repeat rejection within 1 year. And then when we look at our response to cyclophosphamide, we see that 50% of our encounters did respond to cyclophosphamide, and they responded based on some element of cardiac dysfunction or reduced donor-specific antibodies. When we take a closer look at the DSA response, our y-axis here is depicting the DSA MFI value on a post 1:25 dilution. Our x-axis is showing us pre-cyclophosphamide and post-cyclophosphamide DSA values. And then the key on the right-hand side is showing us patient-specific elevated DSAs prior to cyclophosphamide administration. And what we found is that of those patients that did have elevated DSAs at baseline, 60% experienced a decrease in DSAs post-cyclophosphamide. Looking at our patients who had a positive cross match at time of transplant, we saw that 66% of those patients were considered responders to cyclophosphamide versus 40% who were not. So we saw a numerical difference here, although we were not able to find a statistically significant difference. Looking at rejection within 1 year post-cyclophosphamide, we saw that 67% of patients who were considered non-responders experienced rejection versus only 16% of responders experienced rejection post-cyclophosphamide. And our median time to next rejection episode was around 3 months for non-responders and 1 month for our responders. So future directions for my research include reviewing our current cyclophosphamide for administration protocol and making any necessary changes. And then finally working with our team to determine if cyclophosphamide therapy is beneficial in treating AMR recipients. And that concludes the end of my presentation. I'll take any questions or comments that you have.
All right, I'm not hearing any questions for Emily, but great job. And thank you to everyone for sharing your work with us. And thank you everyone for coming and listening to these great presentations. I hope you all have a great evening.